Another very important feature in terms of evaluating patients with suspected stenosis is to be able to profile that stenosis, and we just wanted to go over an example of that with you in this set of 4 slides. You can see here on the top left, we are what I call in the pre-stenotic area, where we're evaluating the common carotid artery proximal to a suspected lesion right here at the origin of the internal carotid artery with acquisition of this spectral waveform. We would then move on through that stenosis, eliciting the highest velocity within that lesion. And the way that's done is by moving that sample volume back and forth throughout the color flow image, up and down within the vessel, to find the highest velocity within that lesion, keeping in mind that this is the velocity that should be reported to your interpreting physician. The highest velocity is the one that will be used in the estimation of the stenosis range. The sample volume is then moved beyond the lesion into the area of just immediately beyond the tightest part of that stenosis, where you should see a spectral waveform that looks something like this. This is what we refer to as post-stenotic turbulence, and you really should be seeing post-stenotic turbulence in any patient in whom you suspect a hemodynamically significant stenosis. The absence of this type of a signal beyond a hemodynamically significant stenosis, when it's suspected, really should prompt you to go back and really evaluate that area. Post-stenotic turbulence will almost always be present when you're looking at a patient with a hemodynamically significant stenosis. And then we see here that we've moved the sample volume well beyond that area of stenosis to get a look at that distal internal carotid artery waveform. Sometimes the degree of spectral broadening and occasionally the presence of a tardus parvis waveform way out here beyond the stenosis will give you an idea about the severity of that lesion. So this is what we refer to as profiling the stenosis, to elicit the highest velocity within the stenosis and to confirm the presence of a true stenosis by demonstrating the presence of post-stenotic turbulence. In terms of the examination itself, we like to test our patients on the examination table with the patient supine. As you can see in these images, it's okay to examine the patient by standing up and facing the patient, or you can sit at the patient's head. I think either one is okay, and I think you should do whatever you feel most comfortable doing. Of course, access is important. You need to remove any tight sweaters or chains that don't allow you access of the carotid artery system from the level of the clavicle here at the base of the neck all the way up to the angle of the mandible. You really need to have access to do this study well. So if there's any tight sweaters or turtlenecks, we remove those. And of course, you want to be doing both sides. We always start the examination by evaluating the right side first. So we'll turn the head slightly away from the right toward the patient's left, and we like to have the chin pointed up. A little bit of a technical tip here in patients with very short necks or very high bifurcations. You can sometimes put a little pillow underneath the shoulders, and that will hyperextend the neck to give you more access to the distal internal carotid artery. Now, we start off every examination with what I like to refer to as a transverse sweep. And this is just a short axis sweep that starts at the base of the neck and then works its way up to the bifurcation of the carotid artery vessels. And we do this because it gives us a nice preview of the extracranial system. It allows us to get an idea about the location of the bifurcation. In some patients, it will help you differentiate the internal from the external carotid artery. It will, if you put your color on, it will very quickly allow you to assess for patency of the common carotid artery branches by the presence of color within those vessels. And it also allows us an opportunity to note any extracarotid pathology, particularly the thyroid. And in patients with plaque, it allows you to determine the location as well as the extent of plaque burden within the carotid arteries. Every examination, of course, starts out with an evaluation of the most proximal common carotid artery. Now on the right, because of the anatomy and because of the presence of an innominate or brachiocephalic artery, you can almost always see or image the origin of the common carotid artery. And when you can, I think it's appropriate to go down there and look. So we image the proximal common carotid artery and we look at the flow waveforms. This is used to determine for the presence of proximal disease. Keep in mind, especially in patients with very focal and moderate levels of disease who have symptoms referable perhaps to a stenosis at that region, If you're too far downstream, you may in fact miss that lesion because the flow waveforms tend to normalize the further you move away from a stenosis. So if you can get very proximal in these patients, you're likely not to miss those lesions. Disturbed flow is not uncommon because of the proximity to the heart in these patients. And of course, it may be more prominent on the right because you can get much closer to the origin on the right. I think the important thing in these patients is to look for side-to-side asymmetry in terms of both the velocity, the waveform, and the size. And while I'm on that topic, keep in mind that within the carotid system, asymmetry is very important. There really should not be much difference between the right and the left carotid arteries, although you may know the difference when you're looking at the vertebral arteries. So, evaluation of the common carotid artery again starts out at the origin. Another reminder is that we should be evaluating the whole length of the carotid artery system using all the tools in your toolbox, and we always use color. In the old days, before we had color, we had to take that sample volume and step it through and move that sample volume up and down and back and forth within the carotid artery system. However, again, one of the advantages of color flow imaging is that it allows you to see a wide field of view. And what we do is we allow the color flow image to tell us where we need to stop within those areas of those predetermined sites for evaluation. Any area that looks suspicious by the color flow image really should be evaluated by spectral Doppler. In the absence of any evidence of a flow disturbing lesion or any other pathology within the carotid system, of course, we would stop at those predetermined sites to evaluate and to acquire velocities. But our next stop within the carotid artery system then would be the mid-common carotid artery, somewhere that's relatively low in the mid-neck, in an area of the vessel where it's straight and where it's disease-free. And this is an important part of the evaluation, especially if you're using an internal carotid to common carotid artery ratio. The literature states that velocity should be acquired somewhere 2 to 3 centimeters proximal to the carotid bifurcation, again in an area where the vessel is straight and where it's disease-free. One of the other reasons to look at this part of the common carotid artery is to compare the end diastolic flow velocity to the contralateral side, keeping in mind that asymmetry should be noted and interpreted appropriately. For instance, the absence of diastolic flow ipsilaterally really should clue you into the possibility that there may be something going on distally. On the other hand, if you're looking at a parvus tardus waveform where you have decreased velocities on one side versus the other, you have to start thinking about the possibility of more proximal disease. If you note any areas of flow disturbance or plaque within the carotid artery system, anomalous waveforms, that really does require an explanation. And if you do see flow disturbance in the absence of having been able to detect a high velocity proximal to that, you really need to go back so you can explain that finding. In the absence of being able to explain that finding, you really need to qualify your report accordingly. The next stop then would be the distal common carotid artery, and what we like to refer to as the flow divider or the bifurcation. And I know some people may call this the bulb, but keep in mind that the bulb could have involved any portion of the common carotid artery system, including the internal and the external carotid arteries, or it may not involve any portion of the carotid system at all. Now, the bifurcation may be an area that is dilated and bulbous, and it is an area where you may develop disease, and this is the reason why we like to stop here and acquire a flow velocity, keeping in mind that the highest velocity within a stenosis, if the disease does involve the bifurcation and the internal, may in fact be at the level of the bifurcation, and you wouldn't want to miss that by reporting out a lower velocity acquired within the internal carotid artery. The waveforms at this level may be a little bit different than those that you've acquired more proximally in terms of the diastolic flow component, and that's okay. That's something that we expect and something we don't get too excited about. Again, because the disease may be a little bit more severe at the bifurcation, if the velocity obtained at the bifurcation is higher than that obtained in the internal carotid artery, then that would be the velocity that you use in your ICA to CCA ratio. It's also important if you see plaque and disease in this area to evaluate the vessel from multiple views when you're attempting to elicit the highest velocity within that lesion. Now, once we've moved beyond the bifurcation, it's now very important to be able to differentiate the internal from the external carotid arteries. And the primary way to do that is by evaluation of the waveforms. Keep in mind that the external carotid artery will have less diastolic flow than the internal carotid artery in normal cases. Sometimes tapping on the superficial temporal artery will help in that it causes oscillations within the external carotid artery. However, keep in mind that if you do elicit these oscillations within the external, you really should go back to the internal and do some tapping there to make sure that you're not seeing oscillation within the internal as well. If you're seeing oscillations in both vessels, then this parameter will not be useful. In fact, tapping of the superficial temporal artery really is the least useful of all the parameters in terms of differentiating the internal from the external carotid arteries. The external carotid artery does have extracranial branches. This is something that you will not see within the internal carotid artery. So the presence of branches when you're evaluating these patients will help in terms of identifying the ECA versus the ICA. However, keep in mind one of the pitfalls is that if you do not see branches, this does not necessarily mean that you're looking at the internal carotid artery. It only means that you're not seeing branches. So it's the presence of branches that's helpful when differentiating the ICA from the ECA. The internal carotid artery is usually larger and anatomically is positioned posterior and lateral to the external carotid artery. And typically in most cases when there is a bulb, it will be associated with the origin of the internal carotid artery. And here we have just a few images to show you how I evaluate these patients. In this case here on your top left, we'll note two vessels beyond the bifurcation. Here is one on the near field and one here in the far field. And we can see here in this vessel, which is a little bit further away from the transducer, we see several branches. This, of course, would be the external carotid artery. We can see also that at the origin of the internal carotid artery, this vessel is bulbous. Again, some evidence that this would be the internal. But really the primary way to tell the difference is by looking at the waveform, so that when we look at this vessel here, the one located more anteriorly, we see a waveform that yields continuous forward flow throughout diastole, much more diastolic flow than its counterpart, the external carotid artery, which has a sharper peak, much less diastolic flow. And here in this 2D image, without color, we can see the presence of several branches. All of this confirming that, in fact, we are looking at the internal carotid artery in this vessel and the external carotid artery here in the far field.